Hello everyone and welcome to Chapter 13, which is BLS Resuscitation. Basically this chapter is an overview, a review, if you will, of what we've already done earlier in the program with the AHA CPR protocols and guidelines. This is basically that entire course, the AHA CPR course in Word format as a chapter in your textbook. So we're not going to usually lecture this chapter in class just because we've already done that program with you guys in person. But I did want to record this and have it available for you if you did want to hear the actual lecture again. And of course, BLS Resuscitation, CPR as a whole, is one of the bread and butter aspects, if you will, of an EMT's job performance. So knowing this information really well is not only going to benefit you on exams, but it's going to benefit you when you get out into the field. So, of course, we're going to skip the introduction slides here and move on right to get into this lecture. So, elements of BLS. Of course, this is called BLS, which stands for Basic Life Support. So that entails anything that's non-invasive emergency life-saving care. And this non-invasive aspect of life-saving care is why we call it BLS. Anything that's more invasive, which would involve medications and needles and the placing of IVs or the placing of IOs into the bone, all involve a lot of training. It involves a lot of protocol work, approval from medical directors, and so on and so forth. So invasive care usually falls under the jurisdiction of ALS, which is advanced life support, and non-invasive, like we're going to talk about today, is BLS. So that's really what defines what is BLS. Is it invasive or non-invasive? And of course, what we're dealing with as EMTs is non-invasive. So the protocols that we have are used to treat medical conditions, including airway obstruction, where the airway has become blocked, respiratory arrest. Remember, going back to our medical terminology, arrest means the cessation of or the absence of. So respiratory arrest would be apnea, which is the patient is not breathing anymore. And cardiac arrest, of course, would mean that the heart is no longer beating. The focus is on the ABCs, of course. The ABCs entail the primary assessment of any patient that we come in contact with, no matter what their chief complaint is, their NOI, MOI, no matter why we receive the call. Our primary focus is always going to be the ABCs, and that stands for airway, breathing, and circulation. Ideally, only seconds should pass between the time that you recognize a patient needs BLS and the start of your treatment. BLS a lot of the times is synonymous with CPR. Remember, CPR stands for cardiopulmonary resuscitation. Resuscitation means interventions that we enact for the patient to ensure that oxygenated blood flow is still being circulated around the patient's body, right, in efforts to keep the heart and the brain perfused. Remember that perfusion means the circulation of oxygen and nutrients, meaning glucose, in adequate amounts to all of the cells to meet their demands. Those cells use oxygen and glucose to create ATP, which is cellular energy. Without cellular energy, ATP, the cells will not be able to perform their function, as well as they won't be able to survive. So permanent brain damage is possible if the brain goes without oxygenated blood flow for 4 to 6 minutes. We're going to see in a chart here coming up. But the purpose of CPR is to resuscitate or enact measures to move oxygenated blood flow throughout the body in efforts to keep myocardial tissue, the heart, and cerebral tissue, the brain, alive. If we do that very quickly, the patient has a better prognosis in terms of survival and in terms of quote-unquote bringing somebody back, restoring circulation, spontaneous circulation on their own. So you can see here, on this chart that time is critical. This is talking about cerebral tissue mostly, but you can see from 0 to 1 minutes here. Without oxygenated blood flow, you will have cardiac irritability, right? The heart does not want to give up. We talked about in chapter 6 a special component of the myocardial cells, which is automaticity, and that means that every single cell in the entire heart muscle has the ability to create or replicate an electrical signal without any intervention from any other part of the body. So every single cell in the heart has the ability to create its own electrical signal, which means it's important because the heart is a workhorse. It does not want to stop. So if all of the cells can create an electrical signal, theoretically, the heart will keep beating. It wants to keep beating. However, the heart is a muscle, just like any other muscle in the body, and it needs a constant supply of oxygenated blood flow to perform its function. Of course, those cells need to create ATP to perform their function, to create that electrical stimuli. So it's 0 to 1 minute without oxygenated blood flow to the heart muscle. The heart isn't going to stop necessarily, but most likely it's going to be extremely irritable because it's not getting what it needs to survive. From 0 to 4 minutes, brain damage is not likely. So if we can restore oxygenated blood flow circulation to the brain, we can preserve as much brain tissue as possible. From 4 to 6 minutes without oxygenated blood flow, brain damage is very possible. Now we're getting into the realm of risking larger areas of infarcted tissue of the brain. Infarction means actual death of tissue from prolonged cessation of oxygenated blood flow to these tissues. 6 to 10 minutes, brain damage is very likely, and this is one that you should pay attention to because you might see it for testing purposes, the difference between brain damage being possible and brain damage being extremely likely, like they're saying, in the 6 to 10 minute range. And more than 10 minutes without oxygenated blood flow, brain damage is irreversible. That means large quantities of the brain are now starting to die. And of course, like we talked about, the brain controls everything in the body. If the brain dies, then the patient will die. This is the major cause for fatality in patients is when the brain cannot be perfused, cerebral tissue will die, and once that cerebral tissue dies, you cannot get it back, no matter how much blood flow you put through it. Once it dies, it's gone. So if you lose too much of the brain, you will not be able to get the patient back, so to speak. Cardiopulmonary resuscitation, right? CPR, resuscitation, like we talked about, efforts that we do on our part as emergency providers to restore oxygenated blood flow to the body, right? And of course, we're trying to perfuse the heart and we're trying to perfuse the lungs. So in essence, CPR is a combination of establishing circulation, like you see here, and we do that by chest compressions. We're actually mimicking the contractive effort of the heart so that we can circulate blood through the body without the heart actually beating. And artificial ventilations, in reference to using the BVM to ventilate the patient and introduce oxygenated blood flow, introduce high concentrations of oxygen into the lungs so that that oxygen may move into the bloodstream so that we can circulate. If we put these two together with chest compressions and ventilations, we are now circulating oxygenated blood flow through the body. Steps of CPR, we're going to restore circulation primarily by performing chest compressions. We're going to open the airway and make sure that it is not only clear, but that it remains open, and remember we call that patent. And we are going to restore and assist breathing by providing rescue breathing. Now, it's very important for you to understand a couple of things moving forward. Patients receive CPR because they are in cardiopulmonary arrest. Cardio in reference to the heart, pulmonary in reference to the lungs, and of course, arrest means the cessation of. So we only provide CPR for patients who are dead, and we call those presumptive signs of death. They're presumptive because the heart is no longer beating, the patient is no longer breathing, and if they stay that way for too long, they will definitively be dead. But at this point, there might be something that we can do, i.e. CPR, to restore circulation, to bridge the gap between when we found them with zero oxygenated circulation of blood flow and either their definitive death, or hopefully we can actually return spontaneous circulation and the patient can survive. So we only perform CPR on patients who are dead. We only start CPR on patients who are dead. CPR is only indicated for patients who are dead. It's incredibly important for you to remember that. CPR only comes into effect if the patient is dead. So the three things that we look for to know that we need to start CPR on a patient is that they are pulseless, they don't have a heartbeat, apneic, which means they are not breathing, and the third one is unresponsive. Of course, if your heart is not beating and your lungs are not providing oxygen to the bloodstream, there is no chance that you will be conscious, that you will be awake. So if the patient does not have a heartbeat and they are not breathing, then of course unconsciousness is a given. So the three things we need to recognize before we start CPR to know that a patient is dead is pulselessness, apnea, and unresponsiveness. You also have to understand this point right here, providing rescue breathing. Okay, that rescue breathing has to be done artificially, which means we have to manipulate their ventilations. Remember, going back to the chapter 6, when we're talking about the physiology of the respiratory system, there's two fundamental differences between ventilation and respiration. Remember that ventilation is the mechanical movement of air into and out of the lungs. And respiration is once that air that's brought into the lungs moves past the dead space and reaches the alveoli, there we will have hopefully the exchange of gases, where oxygen will move into the bloodstream and carbon dioxide will move out of the bloodstream. And they're two separate but interdependent functions. You cannot have the exchange of gases in the alveoli unless air is brought into the lungs, into the alveoli. So we cannot manipulate respiration, but we can do something about whether or not the patient is ventilating. If the patient is not breathing, we have to use the BVM to force air into their lungs so that we can make sure that oxygenated air is actually getting all the way down to the alveoli. So again, we perform chest compressions to mimic the heart's ability to circulate blood throughout the body, and we use the BVM, not the non-rebreather, the BVM to provide assisted or artificial ventilations to force air into the lungs. Here you can see a picture of a setup of what it would look like for a two-rescuer CPR. You have one partner that is doing chest compressions, okay, to circulate blood throughout the body, and you have another partner who is ventilating the patient with the BVM, okay. Remember that the non-rebreather will not work in this situation. A non-rebreather is not indicated for patients who are not breathing. Remember, the non-rebreather's job is to increase oxygen around the mouth and nose, but the patient must be breathing on their own to bring in that oxygen into the lungs. So the BVM is our way to artificially ventilate the patient, like I said, to force air into and out of the lungs. Of course, a couple other notes about this picture. You can see over here that the oxygen tank is correctly set up. It has the regulator attached to it. It has the the BVM hose attached to it. And my favorite thing is it's laying down on its side. Remember to never leave an oxygen tank standing up on its own because it could fall over and it could sustain damage, and it could actually turn into a deadly missile. So it's always important, if you don't have a hand on the oxygen tank, to lay it down like you see in this picture. Of course, we know that BLS differs from ALS, which is advanced life support. We talked about BLS really falls under the jurisdiction of EMTs, and ALS involving cardiac monitoring, intravenous fluids and medications, and advanced airway adjuncts like ET tubes, those breathing tubes that move that are placed into the trachea. All of those things are outside of the EMT scope of practice, so ALS would fall under the jurisdiction of nurses and doctors and paramedics. But BLS and ALS both have their place in terms of CPR. BLS, we have a saying in the field for ALS providers that BLS always comes before ALS. That BLS should be our bread and butter. BLS should be where we start every single time. So instead of going straight for placing an IV or placing an IO and start pushing fluids and drugs and all this kind of stuff, we have to go back to the basics and remember that BLS is the most important. The idea of using chest compressions to circulate blood and using positive pressure ventilations with the BVM to supply oxygen onto that bloodstream that now we're circulating. So, but ALS, like I said, has its place because the patient might be exhibiting different cardiac dysrhythmias that we can try to fix with medications. The patient will greatly benefit from different medications that we use during a code situation. And if we do place an advanced airway adjunct, we can ventilate through the ET tube and know that we have a 100% secured airway, and all of that air from the BVM is going straight into the lungs. So we want to start with BLS because that's the foundation, but also ALS does have its role in CPR. So it's always imperative if you're in a situation like this as an EMT provider. That's why we put an emphasis on recognizing the patient's situation and recognizing their need for ALS intervention, and to call dispatch to get ALS on scene as soon as possible if warranted. The system components of CPR, this is referred to as the links in the chain of survival for a patient. So remember we talked about presumptive signs of death. Those are anything including unresponsiveness, lack of a carotid pulse, lack of a systolic blood pressure, lack of breathing. That means that if we see those things on a patient, that they are dead. But it's only presumptive because with the initiation of CPR and these 5 chains in the link of survival being met, there is a chance that we could bring the patient back and they might actually restore their own heartbeat. So that's why we call it presumptive signs of death. Of course, we've already learned about definitive signs of death, which means even with the activation of CPR, even with the 5 links in the chain of survival being met, that patient cannot be brought back to life because too much of their brain tissue has died, too much of their pulmonary tissue has died, too much of their myocardial tissue has died, that the patient now is definitively dead. But if we find a patient who again is unresponsive, pulseless, and apneic, if we activate these 5 links in the chain of survival and all of them are met in an appropriate amount of time, AHA says that the patient has the best prognosis for surviving whatever reason they are pulseless, apneic, and unresponsive. So the first chain is recognition or activation of EMS. So of course we know that a incident has to occur for EMS to be activated. So something has to happen, some issue has to befall a patient for somebody else to call 911, right? They call 911 and tell dispatch about the information regarding your potential patient, and of course dispatch is going to be the one that activates us on a call. Once we respond to the call, the next chain in the the next link in the chain is this one here, which is immediate high quality CPR. In my opinion, this is the most important link in the chain of survival. Just like we talked about, the heart and the brain can only go for so long without oxygenated blood flow. They will die very quickly if blood flow is not restored. So the faster that we can get to the patient and the faster we can start CPR, especially chest compressions, to start circulating blood, the better their chance for survival. Remember, going back to that stopwatch that we found, sometimes it might take us 4 or 5 minutes to even respond to a call. Even if we're on top of our game, it might take us a little while to get to the patient, and we don't know how much cerebral tissue has actually infarcted or died. We don't know how much myocardial tissue has infarcted at this point. So the faster we can start CPR, the faster we can start circulating blood. Also, it's important to remember that theoretically, if a person goes down, if they code from cardiopulmonary resuscitation, they go into cardiac arrest, the moment that they go down and they stop breathing and their heart stops beating, theoretically, they have anywhere from 2 to 3 minutes of usable oxygen that's already been saturated on their hemoglobin. So some of that oxygen is already provided for us, and it's just sitting around dormant in the bloodstream, and it's not moving due to their lack of a heartbeat. So that's why we start with chest compressions first immediately, because we can use some of that oxygen that's already in the bloodstream to circulate it to the heart and the brain to give us an even better chance of preserving cerebral tissue and myocardial tissue. The next link in the chain is rapid defibrillation. We use the AED, of course, for defibrillation purposes. If we can get to the patient very quickly with an AED and apply the AED as soon as we have one to the patient, then we can figure out, or the AED rather, can figure out for us if they are in a shockable rhythm, and the faster we can take them out of that dangerous rhythm, the better. We're going to talk about the AED in a little bit more detail in some slides coming up, so I'll keep moving. The next chain in the link of survival, the next link in the chain of survival is basic and advanced EMS. So again, initiating BLS, transporting them to the hospital, potential rendezvous with an ALS unit so we can start performing some more advanced life-saving interventions, and ALS and post-arrest care. That means getting them to the hospital where they can do even more advanced interventions for this patient. And potentially, like I said, if all these links are met in the chain of survival in an adequate amount of time, the patient has their best prognosis for survival. Okay, this slide here, I'm going to keep moving on because we just talked about all these links in the chain of survival. Assessing the need for BLS. Always begin by surveying the scene, making sure that it's safe and making sure that we are safe to enter. Complete a primary assessment as soon as possible. Of course, the primary assessment entails the ABCs, airway, breathing, and circulation. First off, determine unresponsiveness, right? Sir, can you hear me? Ma'am, can you hear me? Try to determine very quickly if they respond to you. After that verbal stimulus, we can try to introduce some painful stimulus very quickly to gauge if they are truly unresponsive. Remember the purpose of evaluating the ABCs. If you arrive on scene and you find somebody that you deem in your general impression is most likely to be unconscious, the first thing that we want to rule in or rule out is if they're dead. If they're not dead, then we know that we don't have to start CPR. But if they are pulseless, apneic, and unresponsive, then we know that we have to start CPR as soon as possible. So we're trying to get to that determination as quickly as we can. Basic principles of BLS are the same for infants, children, and adults. Although cardiac arrest in adults usually occurs before respiratory arrest, the reverse is true for infants and children, and I cannot stress this enough. What they're trying to say very quickly, I'll explain to you, is generally in adults, say an 85-year-old male that is in cardiopulmonary arrest, over the course of 85 years, that patient has almost invariably been exposed to or had issues with the respiratory system, the cardiovascular system, dealing with problems like plaque buildup, which is atherosclerosis, or plastinization or hardening of the vasculature, which is arteriosclerosis. Generally, the point is older patients have different ailments like cancer and different types of cardiovascular issues start to arise and develop. And so if a older patient, an adult, is in cardiac arrest, usually the culprit is the cardiovascular system itself because it has had the time to develop so many problems. In infants and children, theoretically, they all should have very strong, very well-functioning, efficient cardiovascular systems, unless, of course, they were predisposed to some congenital issue, or they had a heart defect or ventricular septal defect or some other issue that they were born with. If that's not the case, then usually infants and children should have a well-functioning cardiovascular system. But we know that the heart, its ability to work and its ability to survive is contingent upon the ability for the respiratory system to work and perform its function. So in children, infants and children, we put such a high emphasis on their respiratory system because if that fails, then the heart muscle can only survive for so long without that oxygen intake and CO2 output that's only happened in the lungs. So generally, infants and children have well-functioning hearts. If their heart stops, it's usually not a problem with their heart itself. It's usually a problem with the respiratory system not working the way that it should. So it's very important to keep that in mind. Here you see, of course, a provider that is checking responsiveness of a patient that he found on the ground that was not tracking him, was not obviously alert. So now this provider is checking responsiveness very, very quickly and will subsequently check if the patient has a pulse and if the patient is breathing. And if he is unresponsive, pulseless and apneic, this provider should start chest compressions or CPR immediately. Automated external defibrillation, the AED, is a vital link in the chain of survival. In fact, it is the third link in the chain of survival just after the initiation of chest compressions. The automated external defibrillator should be applied to cardiac arrest patients as soon as possible. Let me read that again with a little bit more emphasis. Automated external defibrillator should be applied to cardiac arrest patients, okay, as soon as possible, or as soon as the AED is available. The reason I emphasize that is because registry will try to trick you, and they will try to make it sound, an answer option, sound like it's viable for somebody that has a pulse to say, oh, why don't you prophylactically put the AED on? Why don't you put it on the patient just in case they go into cardiopulmonary arrest, right? This is absolutely not the case. It's very dangerous to put a defibrillator on somebody that doesn't actually need one or is not indicated for one. So the AED is only applied to patients who are, quote unquote, dead, pulseless, apneic, unresponsive. Because as soon as you plug in the pads or turn on the defibrillator, it's going to immediately start to analyze the patient's rhythm. And if the patient, of course, is in a shockable rhythm, then the AED is going to say shock advised and will allow you to discharge the electrical energy into the chest the way that the AED should work. But for testing purposes and for real world job applicable purposes, you need to understand that AEDs do not get used or applied or even thought about until a patient is dead, pulseless, apneic, unresponsive. If you witness cardiac arrest, begin CPR and apply the AED as soon as it is available. Children, apply after the first 5 cycles of CPR. Remember that a cycle is, let me see if I could write it out for you here. A cycle is 30 to 2. And by that we mean 30 compressions for every 2 ventilations, right? Or 2 ventilations per every 30 compressions, the way that you want to, whatever way you want to think about it. So one cycle is performing 30 chest compressions in a row and then breaking for 2 seconds to provide 2 breaths for the patient. This can either be mouth to mask, where you actually put a barrier device over the patient's mouth and breathe into that for your ventilations, or you actually have the BVM with you hooked up to oxygen and you can give 2 breaths. You can ventilate the patient using that method. So 1 cycle is 30 to 2. So 5 cycles would be 2 minutes of CPR. So when it says apply after the first 5 cycles of CPR, that means after the first 2 minutes of CPR, after 5 cycles of 30 to 2. Manual defibrillator is preferred for infants 1 month to 1 year. What they mean here, the manual defibrillator, is different from the AED in the sense for 2 reasons. The manual defibrillator, unlike the AED, allows us to actually visualize the patient's cardiac rhythm in real time, and the manual defibrillator allows us to adjust the joule setting. In essence, it allows us to manipulate how much electrical energy actually moves through the patient. And we have specific protocols as paramedics to use the manual defibrillator on infants from 1 month to 1 year and actually change the joule setting, the energy setting, based on their body weight. So we can do, without getting too far into the protocols, we might do 2 joules per kilogram of body weight or 4 joules per kilogram of body weight. In any case, we can tailor that electrical energy to meet the patient's weight standards, depending on how big they are. If this is unavailable, however, if you only have the AED, you can use the pediatric size pads and the dose attenuating system. This dose attenuating system fits in between the pads and where they plug into the AED itself, the device, and you press the shock button if indicated, and it will send the electrical energy through the dose attenuating system, and that dose attenuating system will automatically decrease or lessen the amount of electrical energy that moves into the pads. So it changes the dose when it notices that device is present to better serve that pediatric patient. However, if neither of these is available, if you just have an AED with the adult pads, we can use the AED with the adult size pads with the anterior-posterior placement. We're used to applying the AED to a adult patient, 1 pad in the right upper area of the chest and the other pad in the left lateral side of the chest. And that electrical energy, once we push the shock button, is going to move from the pad in the right upper placement across the chest through the heart in a diagonal pattern and connects with the pad on the left lateral aspect of the chest. And the reason that we place the pads that way is because that actually mimics the direction of electrical energy that naturally should move through the heart. So what they're talking about with anterior-posterior placement with an infant, when we're using the AED pads, when we're using the adult pads of the AED, we put 1 right in the center of their chest, anterior, and 1 right in the center of their back, posterior. And so that electrical energy will move straight through the trunk of the body from anterior to posterior. In special situations, we will have to change or manipulate the way that we place and use the AED. So as we go through these 3, these were talked about in your AHA CPR course that you already went through, but again, it's good to make a mention of it. So as I go through these, if you want to make a note of how we handle these special situations, remember implanted pacemakers and implanted defibrillators are usually in the chest. Sometimes they're in the right upper portion of the chest, left upper portion of the chest. They might even be implanted laterally, like more in the axillary under the armpit, over the lateral side of the rib cage. But in any case, if you find a pacemaker or an implanted defibrillator, you're not going to discharge the AED and cause the pacemaker or the defibrillator to do something extreme like explode and kill the patient. But we don't want that electrical energy to move through the pacemaker or the defibrillator if we don't need to. So what we're going to do is try to place the pad of the AED about 1 inch away in any direction from the implanted cardiac device. For wet patients, of course, water is an extremely good conductor of electrical energy. So there's two situations we might run into. Either they are laying in a pool of water or a puddle or something like that, or they have a bunch of water on top of their chest and abdomen. In any case, if you discharge the AED, that electrical energy actually has the potential to move not through the patient's chest, not through the heart muscle the way we want it to, but it could actually move on top of the chest with the water on the chest, or underneath the body if they're laying in a pool of water. And so to make sure that that electrical energy actually moves through the chest, through the heart muscle the way that it needs to, if the patient's laying in a pool of water, we can take them out of the pool of water very quickly and dry them off very quickly. Of course, we don't want to delay the discharge of the AED if the patient actually needs it, and we don't want to delay CPR efforts any longer than we need to. So the patient doesn't have to be completely dry. So in either situation, remove them from the water and quickly dry their chest just enough to get all of the freestanding water off of their body, especially their chest. And with transdermal medication patches, if you see a medication patch or a nicotine patch or anything of that sort, what we would do very quickly is take the patch off of the body and quickly wipe the area of skin that patch was applied to with a towel. Again, it doesn't have to be completely dry. We're just getting the bulk of whatever that medication or substance was from the patch off of the body before we discharge the AED. Advantages of the AED use. I would know this slide. It's very important. You might see this for examination purposes. The advantages of AED use: it delivers a shock to the patient very quickly. It is easy to operate. ALS providers do not need to be on scene. Okay, of course, this is in your scope of practice as an EMT to administer the AED, to indicate its use, to apply it to the patient and use it appropriately. So you do not need ALS to be on scene to perform this potentially life-saving intervention. Remote adhesive pads are safe to use. This is a really good point. I'm sure you guys have seen the old paddle defibrillators, and even though the paddle defibrillators still performed the same intervention as the self-adhesive pads of the AED, it was very dangerous because you actually had to rub the paddles together to charge them, and then you had to place them in the specific area on the patient's body and actually press a button on the paddles to discharge the electrical activity, the electrical energy. And so they could very easily slide off of the patient's chest, or when providers were rubbing the paddles together, they could accidentally discharge the electrical energy, and that would arc in front of their face, and it could give them really severe burns, or in really severe situations, it could actually kill the patient. So the fact that we have these adhesive pads that are basically big stickers that we can put on the patient's chest means that once we place them, theoretically they're not going to go anywhere. And once you place those pads, it's really hands off. You don't need to touch those pads anymore where the electrical energy is moving. And the larger pad area equals more efficient shocks. So real quick before we move on from this slide, I want to talk about this first one right here. Quick delivery of the shock. I'm going to draw some terrible drawings for you here at the bottom. This drawing that I'm doing for you is a very crude representation of ventricular arrhythmia that we might call VFib. And VFib means that the heart muscle is just quivering. It's not producing any sort of contractive effort. The heart is not beating in unison or in a smooth, uniform fashion, in which case the heart really isn't doing anything at all. The muscle's just quivering. It's not moving blood. So with this first one here, VFib, stands for ventricular fibrillation. And it means, just like I said, the ventricles are fibrillating, they're quivering. So this is one of the shockable rhythms that the AED will read for. That's number one. And number two that I'll draw for you looks like this. Again, this is a very crude representation. Okay. These spikes that we see on the AED, or excuse me, that we might see on an EKG of a patient for this second one, those are very large depolarizations of energy, and those we can assume and that we know are coming from the ventricles. That rhythm that you see that's denoted as number two, that's what we would call ventricular tachycardia. And VTach means that the ventricles are firing too fast. They're beating too quickly. In fact, they're beating so fast that they don't have enough time to even refill with blood. And of course, if the ventricles can't fill with blood, when they contract, they're not going to send out any blood, which means that there is no pulse. The heart is no longer moving any blood. So the way that electricity moves through the heart is incredibly important. Like you see with these first and second rhythms, just because electrical energy is moving through the heart muscle, it doesn't necessarily mean that it's providing or that it's culminating in a smooth, uniform contraction that accounts for the efficient movement of blood through the body. So both of these rhythms we call the lethal rhythms. Both of them will not produce pulses, right? In fact, let me make a little disclaimer. VTach, the second rhythm that you see here, can have pulses, but of course we know that we're only using the AED for pulseless VTach because we're only applying the AED to patients that are pulseless, apneic, and unresponsive. So pulseless VTach, number two, and fib, number one, are both lethal rhythms. These are the rhythms that the AED is trying to identify. So both of these, you would get a shock advised message from the AED. That means that the AED has recognized either one of these two rhythms and that you need to shock it or introduce enough electrical energy into the heart muscle to get it to stop. The purpose of the AED is to put enough electrical energy into the heart muscle to take it out of one of these two lethal rhythms and put them in this third rhythm. I'll put it at the bottom, which you all know as the flat line. Okay, we call that asystole. So the purpose of number one, or the purpose of the AED, excuse me, is to recognize either number one or number two, these rhythms, and put enough electrical energy into the heart to send it to number three, asystole. And there we hope that once the heart muscle has been stunned, now that we've taken out of that lethal rhythm, that the heart and brain hopefully are in enough working order that they can start to communicate with each other and pick back up on a normal rhythm, and that the patient will start perfusing themselves, that they're going to have a heartbeat and an adequate blood pressure, and that they're going to start circulating blood throughout the body on their own. ALS and post-arrest care, we're going to continue ventilation. Here we're going to use the standard 1 breath every 5 to 6 seconds. This is, again, we're talking about post-arrest care. Okay, so you see I've written down this acronym at the bottom, ROSC, which stands for Return of Spontaneous Circulation. So that means that our resuscitative efforts were successful and the patient's brain and heart synced up again with each other, and the heart now is beating on its own and it's able to circulate blood throughout the body. So this is post-arrest care, what we're talking about. So if we need to ventilate the patient after return of spontaneous circulation, we're going to use that 1 breath every 5 to 6 seconds, which is 10 to 12 breaths per minute. We're going to talk about later on how the ventilatory rate changes if the patient, in adults and children, if the patient is in fact intubated, if they have an advanced airway in place. But we're going to talk about that a little bit later on. We need to make sure we maintain a good oxygen saturation. We need to assure that the blood pressure is above 90 millimeters of mercury systolic blood pressure. And of course, this is vitally important. That's why I circled it for you, because like we know, we need to have a good systolic blood pressure to support the efforts of the beating heart. And that blood pressure will aid in actually distributing blood all the way out to the farthest reaches of the body. If the blood pressure is too low, it doesn't matter if the heart is beating or how hard the heart is beating. If your blood pressure, systolic blood pressure, is really less than 80 millimeters of mercury, you're not really getting good, adequate blood flow throughout the entirety of the body. Maybe only to the core, but not much farther than that. We need to maintain adequate glucose levels and, of course, rapid transport to the closest appropriate hospital. Positioning the patient for CPR to be effective, the patient must be supine, which means lying on their back, face up, and on a firm, flat surface. This ensures good depth of compression on our part and allowing for good, adequate chest recoil to allow the ventricles to fill with blood in between compressions. There must be enough space for 2 rescuers to adequately perform CPR, so if they're caught in a really small space, we might take a couple seconds just to move them quickly using an emergency move to get them into an area that has a bit more space for us to adequately perform our duties of resuscitation. An example of this quickly might be somebody that's in a very small bathroom that has gone into cardiopulmonary arrest, and we can use a quick extremity move or a direct lift and carry to take them out into the living room or the bedroom where we might have some more space. And it would be beneficial to log roll the patient onto a backboard. This ensures really quick transportation of the patient up and down the stairs if needed, most likely down the stairs to street level where the ambulance is. And if the patient's already on the long, rigid plastic backboard, then of course they would be on this firm, flat surface that we like. That ensures, like I said, good, adequate depth compressions on our part. Check for breathing and a pulse. Once we have determined that the patient is unresponsive using the AFPU scale, we're going to quickly check for breathing and pulse. And the way that we do that is we check a carotid pulse, and we check for breathing by looking for obvious signs of chest rise and fall simultaneously. That means at the same time. So per the new AHA CPR guidelines, we're going to take 5 to 10 seconds to check for a carotid pulse and breathing simultaneously. If we determine that the patient is in fact unresponsive, pulseless, and apneic, we're going to provide external chest compressions. We're going to apply a rhythmic pressure and relaxation to the lower half of the breastbone or the sternum. That's where your hand should be placed for proper CPR. The heart is located slightly to the left of the midline of the chest between the sternum and the spine. Compressions squeeze the heart, acting as a pump to circulate blood throughout the body. Allow the chest to recoil completely. This is a very important step right here. By allowing the chest to fully recoil between compressions, it means that when you depress the chest, that 2 inches of depth in adults, when you are relaxing, when you're recoiling to provide the next compression, we need to make sure that your hands aren't coming up. If you compress 2 inches in depth, you need to make sure that your hands recoil back that same 2 inches. And that allows for good compression 2 inches into the chest to squeeze the ventricles and pump out blood. And we need to allow the chest to fully recoil that same 2 inches so that the ventricles can adequately expand and fill with a proper amount of blood. Proper hand positioning is crucial. We want to make sure, like we said, on the lower half of the breastbone or the sternum, we want to make sure that our hands are on the sternum, that we're actually compressing the sternum itself, because if our hand placement is too low, below the sternum, the lower third of the sternum is called the xiphoid process, a little cartilaginous tip of the sternum, the book will call it. And if our hands are too low, if we're compressing over that xiphoid process, we can actually break it off, and during compressions, it can do a lot of damage to tissue and vasculature,
which can be extremely detrimental to the patient. So we want to make sure that our hands are on the sternum, the lower half of the sternum. Injuries can be minimized by proper technique and hand placement. Here we can see a cross-section of the body as a rescuer is performing CPR. And you see on this side that you can see this cross-section of the heart with the ventricles here and here. And as this provider is providing good, adequate 2 inches of depth on the compression phase, you see the ventricles are compressed, and that blood theoretically is going to be ejected from the ventricles and circulated through the body. But here on the the right side of the diagram, you can see that the ventricles now are able to expand as the provider is recoiling their hands back this same 2 inches that we did compress on the left half of the diagram. So again, full recoil of the chest is imperative while you're doing chest compressions, so that the ventricles are squeezed and blood is going out, and then that they can fill adequately with blood as our hands are recoiling. And here you see they make a specific point to say that the hands remain on the sternum, and that's important because you don't want to be bouncing on and off the patient's chest while you're doing chest compressions. You should have good 2 inches of compression, good 2 inches of recoil as your hands come back up, but your hands should never leave the surface of the patient's chest. Opening the airway and providing artificial ventilation. Here on the left-hand side you can see the head tilt chin lift maneuver. And this is a maneuver that we use exactly as the name describes, where we're tilting the head backwards and using 2 fingers underneath the patient's mandible to lift the chin. And what that does to open the airway is it takes the tongue, which is the most common cause of airway obstruction in adults, it takes the tongue off of the back of the oropharynx and relieves any sort of obstruction by the tongue and facilitating a good open airway. So this is what we use to initially open the airway for somebody that has no suspected spinal damage. If your patient does have if you have any suspicion of spinal damage with your patient, then we would use the modified jaw thrust maneuver that you see here on the right-hand side. And what you're doing is placing the palms of your hands on the patient's zygomas, their cheekbones, and positioning your fingers under the mandibular angle so that you can use your fingers to displace the mandible forward or anterior, and again that will take the tongue off of the back of the oropharynx and relieve any obstruction that the tongue may have caused. Again, we use the head tilt chin lift for patients with no suspected spinal damage, and we use the jaw thrust maneuver for patients that there is a suspicion of spinal damage. If you determine that your patient is adequately breathing after you open the airway using one of the 2 maneuvers we just talked about, and there are no signs of injury to the head, spine, hip, or pelvis, place the patient in the recovery position. We're going to see on the next slide what the recovery position looks like. We also call it left lateral recumbent because the patient is positioned on their left side. The reason we might put somebody in the recovery position is because it helps to maintain a clear airway. If they do end up vomiting, of course we know if a patient vomits and they're unconscious, there's a huge risk of aspiration, breathing that vomit into the lungs, which is extremely detrimental to the patient. So if they're laying on their left side and they do vomit, that uses gravity to facilitate that vomit draining out of the patient's mouth. And we would need to remember to roll the patient as a unit, which is something we'll get into when we get into C-spine. And the reason they make a point to say up here, if there are no signs of injury to any of the following areas of the body, head, spine, hip, or pelvis, that's because we don't want to lay somebody or move somebody into the recovery position laying on their side if they do have spinal damage or head damage or pelvic damage, because that could further the injury, that could make it worse, and of course that patient most likely would need to lie supine, secured to a backboard. Here we see the recovery position, also called left lateral recumbent, helps to maintain an open airway like we talked about, and allows vomit to drain out of the mouth if they do vomit. The combination of lack of oxygen and too much carbon dioxide in the blood is lethal, so we need to provide slow, deliberate ventilations that last 1 second apiece. So if we're using the BVM, we need to have a slow, smooth squeezing of the bag and refilling of the bag. Of course, the inspiratory phase, when we squeeze the bag and push air into the lungs, that should provide good oxygenated air into the alveoli so that it can undergo respiration. And when we let go of the bag and it's refilling, that is the expiratory phase. And of course, that should provide good elimination of carbon dioxide out of the patient's lungs. If the patient is not breathing, ventilations can be given by 1 or 2 EMS providers. If we need to use mouth to mask or mouth to mouth ventilations for a patient, then a barrier device should be used as a form of BSI to protect ourselves from the germs and pathogens potentially that our patient might have. So here you see a provider using the BVM to ventilate a patient. A couple of things that I want to point out that we like about this picture. You see that, of course, the provider is wearing gloves. You can also see that the provider is using a good CE grip to help adequately seal the mask of the BVM to the patient's face. And we see that the patient is holding a head tilt chin lift as they are ventilating the patient, which facilitates the airway again to be open by taking the tongue off of the back of the throat. For a patient with a stoma, place a BVM or a pocket mask device directly over the stoma. Artificial ventilation may result in gastric distension. That's when the stomach becomes filled with air. If you notice this is happening, the first thing that you should do is reposition your airway and make sure that with either the head tilt chin lift or the jaw thrust to make sure that the airway is clear of any occlusions by the tongue, or that the trachea specifically is clear of any occlusions by the tongue. And we also need to make sure after reopening the airway that we are ventilating appropriately, slow and smooth, that we're not hyperventilating the patient with the BVM, and that we are ensuring a proper ventilatory rate, again at 1 breath every 5 to 6 seconds, which is 10 to 12 breaths per minute. And if you see the stomach becoming filled with air, there's a huge potential for the stomach to void itself, to rid itself of its contents, vomiting. So we need to have a suction unit available in case the patient does vomit. We want to take every step that we possibly can to make sure that the patient doesn't aspirate any of that vomit. So here you can see the 2 pictures of a stoma, right? A surgical opening into the trachea. And it's important to remember that if a patient does have this hole in their neck, that surgical incision into the trachea means that when they breathe in and out, that the air will come actually through this hole in the neck, and they don't necessarily breathe through the mouth and nose like as they should anymore. So if you're ventilating the patient in the presence of a stoma, you can see here that the provider is using an infant-sized BVM mask that fitted to a adult BVM, so you get the adult tidal volume from the adult BVM, but you can create a good seal over the stoma by using an infant-sized BVM mask to fit over the stoma, get a good seal, and you have this adult-sized BVM that provides enough tidal volume to ventilate an adult patient.
Okay, so now we're going to start getting into the specifics of performing CPR for our patients. This is no different than the AHA standards for CPR that you learned during your CPR class that we put on for you guys. or if anybody else is watching this, if you have ever gone through, or if you have recently gone through an AHA BLS class for providers, this is all the same information. This is basically just that course that you took, typed out in Word format and put into a textbook. So all the values, all of the information that we talked about during the CPR day, that's all going to stay the same. But it is incredibly important for you guys, for testing purposes, to know the differences, the little nuances between adult CPR 1 and 2 rescuer, between child CPR 1 and 2 rescuer, and infant CPR 1 and 2 rescuer, and how adult, child, and and infant resuscitation differs between themselves on a whole. So we're going to go over this information before we even get to pediatric resuscitation and infant resuscitation. In the slides, I want to point your attention to page 533 in your book, to table 13.2, and that's going to give you a really good look comparing and contrasting the difference between infant CPR and child CPR. So that's going to be a really good resource for you going forward. But like I said, for testing purposes, you definitely do want to be aware of the differences between adult, child, and infant CPR. So we'll get started here with one rescuer adult CPR. Single rescuer for adult CPR gives both chest compressions and the artificial ventilations. Remember that our compression to ventilation ratio is 30:2. So for every 30 compressions we do on the chest, we're going to provide 2 good quality ventilations for our patient. This is best performed using the mouth to mask technique. It's important for you to remember. You'll actually see on exams that for the best tidal volume that you can get is the mouth to mask method, because you're actually using your entire lung capacity, your entire tidal volume you are giving to your patient when you breathe into their lungs, into their airway. With the BVM, it is rated for about 500 milliliters of air tidal volume, but that would mean that you would have to squeeze every square millimeter of the BVM to get all of that air into the patient's airway. So it's not using mouth to mask, putting your mouth on some sort of barrier device like a BVM mask and blowing into their airway. It's not very good for oxygenation, of course, because you're breathing mostly carbon dioxide into their airway. However, it is very good for tidal volume, for getting air all the way down to the alveoli. I want to remember that for testing purposes. You can use a BVM if you have one for one rescuer adult CPR, but putting the BVM mask on their face, making sure, repositioning yourself, making sure you have a good CE grip with the head tilt chin lift, and giving them 2 good ventilations might take more time than is necessary. Of course, remember that the focus for CPR is the compressions. We want to make sure that we circulate any and all oxygenated blood that's still left in the body to the brain, so that we can preserve the brain and heart, so we can preserve cerebral tissue and myocardial tissue. 2 rescuer adult CPR, always preferable to 1 rescuer. The reasons being, it's less tiring, absolutely. If you are the one that's doing chest compressions, after 2 minutes, you're going to be pretty tired. And if you've never done chest compressions before, you're going to find out how tiring it is when you actually get to do them someday. But you get pretty tired after 2 minutes. And it's nice to be able to switch with a partner that's been resting for the last 2 minutes, who's been focusing on ventilations with the BVM. But in any case, when you are with a partner and you switch every 2 minutes, not only do you get better quality chest compressions than having the same provider doing compressions for 20-30 minutes, and you're still doing the same 30:2 compression to ventilation ratio. So the person that's doing chest compressions for 2 minutes is going to do just that, 1 through 30. Once they reach 30, the person at the head, who has been holding a good CE grip, who already has the BVM hooked up to oxygen and is ready to roll in that regard, is going to give 2 solid breaths, 1 second each, 1 second apart, and the person on the chest can go straight back to giving effective chest compressions. And then at 2 minutes, you switch roles and you start all over again. Switching rescuers during CPR is critical to maintain high quality compressions, right, so that people don't tire out as fast. It's recommended to switch the positions every 2 minutes or 5 cycles of CPR. Devices and techniques to assist in circulation. Active compression to decompression CPR involves compressing the chest and then actively pulling it back up to its neutral position. This is more of a manually manipulating recoil of the chest, like we talked about was so important earlier on in this chapter. You could use the impedance threshold device. It's a valve placed between the endotracheal tube and a BVM. So in ALS CPR protocols for advanced level providers like paramedics, a tube might be passed through the patient's trachea, which gives us, at some point during the resuscitative effort, which gives us a 100% secured line into the patient's airway, so that every bit of air that we squeeze through the BVM and every bit of oxygen that we squeeze through the BVM will eventually make its way only into the trachea and hopefully into the alveoli, so respiration can take place. None of that air is going to be able to escape through the mouth and nose. None of that air is going to be able to move into the esophagus, which can cause gastric distension, which is really dangerous during a code type situation. So a tube might be placed, and the impedance threshold device is a device, of course, that is going to fit between the tube, the opening of the tube, and where the BVM connects to the tube. So it's kind of an intermittent in between the BVM and the tube itself. And the ITD is important because it helps to limit the amount of air, that's adding to intrathoracic pressure between chest compressions. So if we, like we've talked about earlier, if there is so much air that's accumulated inside of the chest cavity, even just from taking a really deep breath and holding it, what that does is it decreases venous return back to the heart. So if there's a bunch of pressure surrounding the heart from fully inflated lungs, then the heart isn't going to be able to expand as much, which means it's not going to be able to bring blood back into the ventricles as effectively. So if we have some sort of device that limits the amount of air that stays in the lungs between compressions, that's only going to be more beneficial because it allows the heart to have more room, in a sense, to expand and fill with blood, so that on the next compression down, there's more blood to send out to the body or to circulate around the body. Here you can see the suction cup type or style device, I guess you could call it, that this provider is using here, that allows you to do compressions downward, and it has these grips, these handles here that you can see, that allows the provider then, after the compression downward, to manually decompress the chest to allow full chest recoil. And over here you see the impedance threshold device, the ITD. This one's called the rescue pod. And like I said, it fits between the BVM here and the endotracheal tube here. So, like I said, it limits the amount of intrathoracic air between compressions, or the amount of air that's in the lungs between compressions, and allows the heart to expand and fill with blood more effectively. The mechanical piston device, a lot of people are going for this device. One of the most popular models is called the Lucas device. And what it is, you can see a picture of in your book, by the way, it's a piston device that's run on compressed gas or electricity that fits a plunger right in the middle of the sternum and actually compresses the chest for you, and you can set the rate, you can set the depth of compression. So it's basically a set it and forget it. You put it on the patient's chest, you set the settings, and it starts compressing, and it has the ability to compress continuously for long periods of time without ever tiring, without ever having to switch. So you're going to see a lot of these become more prevalent in the future. They are pretty expensive at this point, but by and large, more and more departments and more agencies are starting to use these mechanical piston devices. So you might actually have to operate one of these in the near future, but it's pretty cool if you can get your hands on it. Similar to the mechanical piston device is the load distributing band CPR device or vest, and it's almost the same thing. It's a short board that goes underneath the patient's back if they're laying supine to give a hard surface to do compressions on, and a load distributing band that fits across the chest and does the same thing. It automatically compresses the chest for you. I've seen some of these used by long-term transports, critical care transports, flight services might also use these. Of course, it's impossible to do mechanical chest compressions on a helicopter just because there's so little room, and movement to that magnitude could actually affect the way that a helicopter flies through the air. So this load distributing band doesn't take up much space. It can provide some good chest compressions while you are doing something else. Manual chest compressions remain the standard of care, however, at this time. So all that's trying to say is these devices are cool, but they're not really widespread at this point. Not especially if we have plenty of people with two hands that can do compressions, and with numbers that still seem to be working. But rest assured, the more popular these get, and the more departments and agencies get the funding for these devices, you're going to see more and more of them around. Here's a example of the load distributing band. Here you can see the short board that would go underneath the patient's back if they're laying supine, and this load distributing band here that goes across the patient's chest. And again, here you can set the depth of compression, you can set the rate, and then it goes on its own without really any more user manipulation. Infant and child CPR. Again, this would be a good time to reference that chart that I told you about a couple slides earlier, because it is important to know the differences between how we perform CPR from adults to children, and then on to infants. Cardiac arrest in infants and children follows respiratory arrest. It is incredibly important that you understand this concept. You will see questions about it. A lot of the reasoning behind how we get our protocols to do CPR for infants and children follows this essential idea that normally children and infants, unless they have some sort of congenital problem, their hearts haven't been exposed to years and years and years of cholesterol and fatty deposits and baked fried foods and oils and bouts of MIs and arteriosclerotic and atherosclerotic disease processes, basically saying infants and children should have healthy hearts when they're younger. So usually the heart's not just going to give up. Most of the time, 99% of the time for infants and children, if there's a problem with the airway, we know that infants and children have twice as high respiratory rates to support their metabolic process because they're growing so rapidly. Their airway is incredibly important. And if the airway stops functioning the way that it should, then in turn will start to affect the way that the heart and brain perform their functions. So usually, if sudden cardiac arrest happens in infants and children, it's usually because of respiratory problem. So airway and breathing, chest compressions are still going to be vitally important, but the way that we manage their airway and the way that we ensure adequate breathing is going to be the focus of how we treat pediatric patients for CPR. So here's some different causes of child respiratory problems. Injury itself, trauma to the airway or to the chest of a pediatric patient, infections, we've already talked about, and we'll continue to talk about different types of infections that children are really predisposed to because their immune systems are still developing from birth, like epiglottitis, croup, pertussis, RSV, all those different kinds of issues that are really common for children could cause such swelling in the airway that it actually could partially or completely close off the trachea. You have to remember in an infant, the diameter of their trachea is really not much bigger than the diameter of a drinking straw. So they don't have that much room to work with, and if the tissue of the upper airway swells to such magnitude, it could actually impede the way that air goes into and out of the lungs. So that could cause a respiratory problem, which could lead to cardiac arrest. They could have some sort of foreign body obstruction. Children, of course, are infamous for putting things in their mouth that they shouldn't, toys and candy and prescription medications, all that kind of stuff could get stuck and again impede the way that air goes into and out of the respiratory system. Submersion in water, drowning, of course, electrocution, poisonings or overdose, and SIDS, which is sudden infant death syndrome. We'll talk about SIDS much later in the program. Determine unresponsiveness, just like for adults, we are going to check for the 3 criteria to start CPR, which of course is unresponsiveness, apnea, which means the patient is not breathing, and we're going to check for a pulse. For pulselessness is the last criteria to start CPR. So we're going to determine unresponsiveness, gently tap on the shoulder and speak loudly. If it's a baby, you can try to tap the sole of the foot. Check for breathing in a pulse. Assessment can occur simultaneously. Remember that this is the big new push from AHA to shorten the time from our arrival on scene to the start of chest compressions, is to check for breathing and pulse simultaneously. So it's checking for a pulse and observing for any signs of chest rise and fall without stopping to look, listen, and feel for the chest. Specifically, that if you don't see any immediate signs of chest rise and fall, that means that the patient is apneic. So you should check for breathing and pulse simultaneously for no longer than 5 to 10 seconds. Of course, for a child, we're going to, if they are unconscious, we're going to check for a pulse at the carotid pulse site, and for an infant, we're going to use the brachial pulse site. Foreign body obstruction in children is very common. Place an unresponsive, breathing child in the recovery position. Of course, remember that's the left lateral recumbent position. The techniques for opening the airway are modified for pediatric patients. We can use the head tilt chin lift or the jaw thrust. We wouldn't really use the jaw thrust for infant patients. Place a wedge under the upper chest and shoulders when they are supine. Again, this gives us a good solid surface underneath the back while they are laying supine to deliver good quality chest compressions. Provide rescue breathing. If the patient is not breathing and has a pulse, we're going to deliver 1 breath every 3 to 5 seconds. If they are not breathing and they do not have a pulse, we're going to give 2 breaths after every 30 compressions. And again, this isn't exactly the same for every situation for infant and child CPR, so I would refer to that table that we talked about a couple times now to know the explicit differences between infant and child CPR. Interrupting CPR. CPR is a crucial life-saving procedure. It provides minimal circulation and ventilation until the patient can receive defibrillation. Remember, that's one of the main links in the chain of survival. AHA's chain of survival is early defibrillation. ALS treatment and definitive care at the emergency department. If no ALS is available at the scene, provide transport per your local protocols, and consider requesting an ALS rendezvous en route to the hospital. That basically means on your way to the hospital, stopping and meeting up with an ALS crew that can help you from there on out with the code. Try not to interrupt CPR for more than a few seconds. The book has this pegged as do not interrupt CPR for any reason for longer than 10 seconds maximum. And that is, of course, one of the 5 criteria that needs to be noted while you're performing your chest compressions during the CPR station, the National Registry station that you're going to have to perform. Chest compression fraction, the total percentage of time during a resuscitation attempt in which chest compressions are being performed, should be at least 60%. There's a way of calculating how much time you're actually spending doing compressions during an entire resuscitative effort. And sometimes they've figured out that providers have been too busy doing other things or not holding to that minimal interruptions, no longer than 10 seconds apiece, in which case they're doing compressions less than 60% of the time. So, of course, our resuscitative efforts, ideally, we want to have them above 80%. We want to make sure that we are delivering chest compressions for the majority of a code situation. When not to start CPR, the first one, of course, is the scene is not safe. The most important consideration for any call, any patient, any situation is, of course, your safety first as a provider, and then your partners. So if the scene is not safe to begin with, we're not even going to enter the scene, which means we're not going to start CPR on that patient. One of the other major considerations, of course, is this bullet point here. If the patient has obvious signs of death, remember we talked about presumptive death, which means that the patient is pulseless and apneic, but there is still a chance that we could bring them back. They're not showing us any definitive signs of death. Definitive signs of death means that this patient has died a while ago and is in no longer need of CPR because no amount of resuscitative effort will bring that patient back. This is usually conducive to cerebral death, which means, of course, that the patient is truly dead. Some of these signs that we can look for are these bullet points here. Rigor mortis, which is stiffening of the body, usually occurs between 1 and 3 hours after death. The same for dependent lividity, which is when the vasculature starts to, the proteins that hold the vasculature together start to decompose or denature, and the blood actually will seep out of the vasculature and will pool in the lowest point of gravity on the patient, which of course would be whatever position they died in. If they died on their side, then all that blood is going to pool up on that side of the body. If they died on their back, if they died in the supine position, all that blood is going to be pooling up on the back. Putrefaction, which is specifically the smell of decomposition of the body, that is very, very evident, or any evidence of a non-survivable injury like dismemberment or extreme exsanguination, which is bleeding out, or of course the obvious one, which would be decapitations. Here you can see an example of dependent lividity, which is, like I said, the vasculature starts to seep all that blood, and that blood will pool and collect in the lowest place of gravity. So this patient died on their back while they were lying supine, and of course you can see, to give you a scale of the amount of blood that pools in the back, here's a handprint of a provider that rolled this patient over onto their side. So you can see a lot of blood that is starting to pool, that bruising color, really deep purple and red in the back. You can see this greenish color bruising on the side of the patient. That's all blood that has seeped out of the vasculature and is all a part of the decomposition process. If the patient and physician have previously agreed on do not resuscitate orders, if the patient has a DNR, this can be a very complicated issue I would advise you to revisit the specifics of what a DNR is and how to know if they are effective, how to follow the law in that regard, all the way back in Chapter 3, which is the medical legal considerations. Advanced directives expressing the patient's wishes may be hard to find. When in doubt, begin CPR, and if you are really in doubt, I would get medical control on the phone or on the radio and have that discussion with them and help them or have them help you make that call. When to stop CPR. Once you begin CPR, continue until you reach the STOP acronym. STOP stands for different things. That can help you remember some of the reasons why we might need to discontinue CPR. S stands for the patient starts breathing and has a pulse, so that return of spontaneous circulation. The heart now is working again and it's circulating blood on its own. Of course, if that happens, we don't need to deliver chest compressions anymore. T stands for the patient is transferred to another provider of equal or higher level of training. O means you are out of strength. And P means the physician directs you to discontinue CPR. Most likely that would be termination of resuscitative efforts when the physician, quote unquote, calls a patient or pronounces them dead. And remember this bullet point down here. Out of strength does not mean you are just tired, because CPR is labor intensive. It's sweaty, it's hot, you get really tired really fast. But out of strength, O for the STOP acronym, does not mean that you're just tired. It means that you are literally physically unable to continue resuscitative efforts. You cannot go on any longer. Foreign body airway obstruction in adults. Airway obstruction may be caused by relaxation of the throat muscles, which means that the tongue is going to fall into the back of the throat. Remember, we talked about how the tongue is the most common form of airway obstruction in adults. And if you go unconscious and you are laying supine, it is very easy for your tongue to relax and to fall into the back of the throat, causing a blockage. Vomited or regurgitated stomach contents. Of course, we talked about vomiting causes an extreme risk of aspiration to breathe in that vomit or fluid or outside material into the lungs. So the easiest way, of course, to manage this is to suction the airway. Blood can also cause an issue, of course, when not only the presence of blood just sitting somewhere, especially in the mouth or the trachea, but if that blood begins to clot. If it sits around for too long, the blood is going to coagulate or clot, which can cause even further issues. Damaged tissues, dentures, and foreign bodies themselves, such as food or other sorts of materials that might get caught in the airway. In adults, it usually occurs during a meal on accident. When you're eating too fast and you take a big bite of something, you don't chew it up all the way, it could become lodged in the trachea. In children, usually occurs during a meal or at play. Patient with mild airway obstruction is able to exchange air, but with signs of respiratory distress, and it's key to leave these patients alone. Now, here's where I want to make a very important point when we're talking about foreign body airway obstruction. You need to, for testing purposes, be able to articulate how we classify a patient as having a mild airway obstruction and how we classify patients that are having a severe airway obstruction. So I'm going to go over that quickly right now. And you also need to know how to treat each circumstance. So in a mild airway obstruction, that means that there is a partial blockage to the trachea. It means that the patient can still exchange air. It means that they can still talk to a degree, or they can whisper, or they can cough. In any case, there's air that is being able to move in and out of the trachea to some degree. So what we want to do is we want to sit them forward and encourage them to cough. We don't want to intervene in the sense of doing abdominal thrusts or the Heimlich maneuver or back slaps or anything like that. We want to sit them forward, encourage them to cough. Hopefully they can expel that foreign body under their own strength. And of course we want to put them on high flow oxygen. So any air that they can breathe in is as oxygenated as we can get it. A severe airway obstruction is classified by complete obstruction of the trachea. There is no air movement into or out of the trachea, which means the patient cannot breathe at all. They might present with that universal sign of choking, which is the hands around the neck with obvious respiratory distress, and of course panic and anxiety. But more importantly, we look for signs that air is no longer able to move into and out of the respiratory system. So they will not be able to cough, they will not be able to speak or whisper. There's no air movement at all. This is a very serious situation. Now we must intervene. And for adult patients and pediatric patients, what we're going to do are the abdominal thrusts, which we're going to see a picture of here, also called the Heimlich maneuver. But those abdominal thrusts are our efforts to generate enough upward pressure through the respiratory system to expel whatever is causing the blockage up and out of their mouths. While we are performing the abdominal thrusts, if we cannot dislodge the obstruction, of course, oxygenated blood flow to the brain is going to be impaired, and eventually the patient is going to pass out. They're going to become unresponsive or unconscious. And when that happens, we're going to lay them down supine on the ground and start chest compressions. We're going to do 30 to 2 compression to ventilation ratio, just like normal, but instead of doing 2 ventilations, we're going to open the airway and see if we cannot easily remove the obstruction from out of their airway. It's imperative that you understand that in this patient with a known or suspected foreign body obstruction, when we do the 30 compressions and then we pause for the 2 breaths, do not ventilate them. If you apply the BVM and ventilate the patient, that pressure generated from the BVM can actually force that foreign body obstruction deeper into the trachea and cause more of a problem for your patient. So it's very important for you to understand those concepts of how to classify a mild airway obstruction versus a severe airway obstruction, and then the differences between how to treat them. So make sure that you know that. So just like we talked about previously, sudden severe obstruction is usually easy to recognize in responsive patients. In an unresponsive patient, we might suspect that they have a severe obstruction. If maneuvers to open the airway and ventilate are ineffective, you meet a lot of resistance while you're trying to ventilate the patient with the BVM. That's one of the most common cases for us as providers to suspect that something might be blocking the trachea. Abdominal thrust maneuver, or the Heimlich maneuver, is recommended in responsive adults and children older than 1 year. Here you can see, of course, again that this female patient is doing the universal sign of choking like I described. Okay. And this provider here is doing effective abdominal thrusts, or the Heimlich maneuver, for this patient. So what you want to do is get behind them, and you want to use one hand to feel for where their navel is, their belly button, and place a closed fist just above that, about a ½ an inch above that. Put the other hand, like you see in the picture, over the top of your clenched fist, and you want to rhythmically apply upward forceful pressure. And again, that's trying to stimulate enough pressure moving through the respiratory system to expel that foreign body out of the airway. Instead of abdominal thrust maneuver, use chest thrusts, which is the same thing I just described on the previous slide, just now up on the chest. For the following responsive patients, we want to use chest thrusts for women in advanced stages of pregnancy for obvious reasons, and also for obese patients, just because it might be difficult to wrap our arms all the way around their stomach or their abdomen. We can get a good grip or a good hold on the patient using chest thrusts in this situation. Just like you see here, it's exactly the same thing as what we described earlier, but now your hand placement is not going to be just above the navel, it's going to be on the chest. For unresponsive patients, determine unresponsiveness. Of course, this is when we're going to use AVPU. We're going to check for breathing in a pulse simultaneously, as we talked about earlier. If a pulse is present and breathing is absent, attempt ventilation. So we're going to go ahead and open their airway with the head tilt chin lift or the jaw thrust maneuver, place an OPA if it's indicated, and attempt ventilation. If 2 attempts do not produce visible chest rise, then we're going to start chest compressions. We're going to perform 30 compressions, open the airway, and again, instead of ventilating and potentially making that blockage worse, we're going to look in the mouth and we're going to attempt to carefully remove any visibly seen object in the patient's airway. Foreign body airway obstruction in infants and children is a common, very, very common problem. If there are signs and symptoms of airway infection, do not waste time trying to dislodge a foreign body. Again, the infection can produce massive amounts of swelling, which is going to make releasing a foreign body from the airway that much more difficult. On responsive standing or sitting child, perform the Heimlich maneuver, just like we described for an adult. On unresponsive child, older than 1 year, manage in the same manner as an adult that we just talked about in previous slides. Here you can see the exact same thing again with the hand placement just above the navel for a pediatric patient, and again the universal sign of choking as displayed by the patient, except now you can see that this female patient is in a sitting position, or a kneeling position behind the patient to generate better abdominal thrusts for this patient that is of course smaller in size than that of an adult patient. Infants do not use abdominal thrusts. Instead, just like we practiced during the CPR course, we're going to perform 5 back slaps, of course supporting the head and neck, and we want to make sure that the infant is supported on our forearm, that we're using our 2 fingers around the patient's mouth to facilitate an open airway, and that we are delivering those 5 forceful slaps right in the middle of their shoulder blades. And it's important to remember that children are malleable, that you're not necessarily going to do them any harm. So really don't be excessively gentle when just delivering these 5 back slaps, because you're not going to harm your patient. But of course, don't be excessively forceful as well. We also want to make sure while we're doing this that the infant's head is lower than their body, and this helps enlist gravity's help in pulling that obstruction out of their airway and towards the front of the patient's body, towards the opening of the mouth. And then after we perform those 5 back slaps, we're going to turn the pediatric patient over and perform 5 chest compressions. Here you can see the infant is supported on the provider's forearm. You can see that the finger is used to facilitate an open airway, and you can see those back slaps delivered right between the shoulder blades. And once we perform those 5 back slaps, on the left you can see, on the right we're going to turn the pediatric patient over onto the other hand and deliver 5 chest compressions. In unresponsive infants, begin CPR, of course beginning with chest compressions. Do not check for a pulse before starting compressions. Open the airway and look in the mouth. If there is an object that you can see, attempt to remove it very carefully. And resume chest compressions if no object is seen in the patient's airway. This might mean that they don't have a foreign body obstruction, or that it's too deep into the trachea that we can't visualize it without invasive means, or without advanced diagnostic equipment. Special resuscitation circumstances. If your patient is in a code type situation because of a known or suspected opiate overdose, we're still going to work the patient, quote unquote, the same way that we would any other patient, which means we're going to determine unresponsiveness, pulselessness, and apnea, and immediately begin chest compressions. So the standard resuscitation measures take priority over the administration of naloxone. However, it could be incredibly beneficial. Incredibly beneficial to at some point administer naloxone to try to block the opiate receptors in the brain and allow the brain to have unimpaired metabolism of oxygen and glucose again, which can increase the patient's chances of survival exponentially. Cardiac arrest in pregnancy is another special resuscitation circumstance. Priorities are to provide high quality CPR and relieve pressure off of the aorta and the vena cava. Grief support for family members and loved ones. Family members may experience a psychological crisis that turns into a medical crisis. Family members and loved ones will remember this event in detail for the rest of their lives, so it's important that you display confidence, tact in your decision making and the carrying out of those decisions, and of course professionalism and empathy. Keep the family informed throughout the resuscitation process. Try to keep them involved in the sense that they understand what you're doing, why you're doing it, and when you are doing something. After resuscitation is stopped, helpful measures include taking the family to a quiet, private place. Use clear language and speak in a warm, sensitive, and caring manner. Exhibit calm, reassuring authority. Use the patient's name. Use eye contact and appropriate touch when needed or when indicated. Expect emotion, expect some sort of a backlash from the family. Not necessarily that they're taking their anger out on you, but that this is an incredibly stressful, physically and emotionally stressful event that they're going through. And we can't necessarily imagine, unless you've been through something like that. If you haven't, you can't imagine what that family is going through or what they're feeling in that present time. So really just expect anything. They could start crying, they could be in disbelief, they might actually lash out at you in anger. So be prepared for that and understand that. Try to empathize with the situation that this family is going through. Be supportive, but do not hover over the family. Ask if a friend or a family member can be called. Ensure that children are not ignored. Education and training for the EMTs. CPR skills can deteriorate over time, so it's incredibly important to keep up with these skills and keep up with the AHA standards of care and their protocols that they've set forth. Practice often using mannequin-based training. This is especially important for you as part of your program. This is one of the skills that you're going to be tested on for National Registry, so you want to make sure that you have an outlet to practice these skills, especially CPR. If you don't touch it for a long time, you're going to forget those little details about how to perform quality CPR, or just not being able to follow along with a National Registry skill sheet. So the sharper you stay with these skills in the program, hopefully the sharper you're going to be when you actually are called upon to perform resuscitation on a patient in the field. CPR self-instruction through a video and or computer-based modules with hands-on practice may be a very reasonable alternative to instructor-led courses, just to intermittently and periodically keep up with those skills over time. Education and training for the public. You are a patient advocate. You must do your part to facilitate the training of lay people in the critical skills of CPR and AED operation. So this not only pertains to you personally staying sharp with these skills and staying sharp with this incredibly important resuscitation process, that you are most certainly going to have to enact or perform or be a part of in the field. But also, we want to make CPR something that's not just sequestered for medical providers or medical professionals. It's incredibly important to have lay people, bystanders that are trained in CPR. So get involved somehow in training your family members on how to do CPR, in becoming a AHA certified instructor so that you can host classes or that you can teach CPR. As well as getting involved with if your specific company or department or agency has CPR training initiatives where they go out into the public to help train people in CPR protocols and AED operations. So there are plenty of ways to get involved and plenty of ways to stay sharp. This concludes the lecture for Chapter 13, BLS Resuscitation. I hope you guys enjoyed. Make sure you keep up with this material. This is a very important chapter. And of course, as always, keep studying hard.